Good day, everyone. My name is Amarachi Uzoma, and today I will be talking about a relatively important topic, a genetic disorder, medical genetics, and the topic is going to be Marfan's syndrome. Okay, so Marfan's syndrome is an autosomal dominant disorder of the extracellular matrix affecting the production of fibrillin, particularly fibrillin 1. And this is the genetic mutation of the gene that codes for fibrillin. Okay, so it's usually associated with tall stature, skeletal, connective tissue, and ocular manifestations. Cardiovascular and ocular manifestations as well. And it affects approximately 1 in 5,000 to 1 in 10,000 live births. Okay, moving on. So what's the genetics of Marfan syndrome? So Marfan syndrome basically has mutation. It's due to a mutation, of fibrillin 1, particularly the long arm of chromosome 15, which codes for fibrillin 1. And fibrillin 1 plays two major roles. So it's a component of extracellular matrix. So that is important for connective tissue. And it also plays a cytokine regulatory role. That is sharing homology with TGF beta binding protein. And TGF binding protein is responsible for sequestrating TGF beta. So if you have less fibrillin 1, you are going to have more activity of TGF beta. And that's what we think plays a major role in the pathophysiology of Marfan syndrome. So TGF beta stimulates the production of collagen, tennessine, periostin, fibropectin, and etc. So if you have more activity of TGF beta, you have more production of these things I've mentioned, collagen, etc. And however, you won't have sufficient fibrillin 1. So the connective tissue is going to be abnormal in this case. And this explains the cause of abundant elastic fibers in the aorta and ligaments, but the complete pathophysiology of Marfan syndrome is still not fully understood. Okay, and as for inheritance, we'll see that 70% of Marfan's cases are familial, meaning that both parents have it. So that means they have a 50% chance of transferring it to the child, or for the child to get Marfan syndrome in this case. And also 30% are sporadic. So it's usually associated with increase in the paternal age. Which can be seen. We know that diseases or other syndromes, take for instance Down syndrome, is usually associated with increase in maternal age, but in the case of Marfan syndrome, we're going to see an increase is associated with increase in the paternal age. Okay, so next we're going to go to the features. Marfan syndrome has several features. It affects several organ systems, and there are usually some specific things that we could see to give a clinical diagnosis of Marfan syndrome. First, we're going to look at the craniofacial features. First of all, the patient usually has long, narrow skull, that we call it dolichocephaly. So usually the patient, I'll show you a picture of the patient having long and narrow skull. The patient usually has recession of the eyeball into the socket. So that's enophthalmos, as opposed to exophthalmos, which is the protrusion that we could see in thyroid diseases. But this one, we're going to have the recession of the eyeball into the socket. And next, we're going to also see anti-mongoloid slant. We're also going to see malar hypoplasia. We're also going to see retrognathia and micrognathia. And the next, we're going to also see some other skeletal features. The patient is going to be tall and lanky, having disproportionate overgrowth of long bones. So when we look at the patient, I'm going to show you a picture as well of this. The patient is going to have long span of the arm. Usually the arm is going to be greater than the total height of the patient by 1.5 times. Also, we're going to have pectus deformity. The chest is going to be deformed like pectus excavatum and also the pectus carinatum. Pigeon's chest also, we're going to see this in the patient as well. Sorry, I forgot to mention also that the upper segment to the lower segment ratio is usually reduced. And what do I mean in this case? Usually the lower segment is typically bigger than the upper segment. I really don't know by what ratio, maybe 0.8, 85 or 86 by ratio, but usually the lower segment is usually bigger than the upper segment of the patient. Next, the patient is going to have arachodactylia, usually very, very long fingers, usually due to one of the reasons due to the joint laxity adding to this. The patient is also going to have kyphoscoliosis, thoracolumbar scoliosis, also inward protrusion of the acetabulum. Usually this is going to be asymptomatic. You probably are not going to see it except if you do radiography. So radiography is going to be the number one way that you're going to see the inward protrusion of the acetabulum. And the next, we're going to see the flat foot, which is the pes planus, the flat foot in the patient, and also the joint laxity as well. Moving on to the next group of features that we're going to see, which is very important, especially for the this plays a role in the morbidity of the patient and also the patient's prognosis over time of patients that have Marfan's syndrome. So going over to the first cardiovascular symptom that we're going to see the thickening of the AV valve, often leading to mitral valve prolapse. Usually this is only heard. It's not like seeing, you're not going to see it symptomatically, but you can hear it on auscultation. But sometimes symptoms might appear in form of mitral regurgitation, which from this can lead to congestive heart failure, especially in children. They can see congestive heart failure, which is usually secondary to this mitral valve prolapse, and we can see signs. Signs can now come out in form of pulmonary edema, pulmonary hypertension, like it can even lead to the early death of the child. Okay, and also we're going to see aortic root aneurysm, again due to connective tissue disorders. We're also going to see acute aortic dissection. Also adding to that, we're going to see dysrhythmias such as AFib. We're going to see also prolonged QT segments as well as SVTs as well. We're also going to see atrial septal defects also in these patients. Next, moving on, we're going to see some ocular manifestations, which is also one of the main prominent things that we see in patients with Marfan's syndrome. First of all, we're going to see ectopia lentis, which is the upward deviation of the lens. So we're going to see it's going to look like a rising sun when the sun is rising, as opposed to in another syndrome, Ehlers-Danlos syndrome, where we can use it as a differential diagnosis to differentiate it from Ehlers-Danlos, which has downward deviation of the length of the lens. Okay, so next we're going to see myopia. We're also going to see hypoplastic iris, ciliary muscle hypoplasia, also increased risk of cataracts, retinal detachment, glaucoma, and so on and so forth. So these are some of the ocular manifestations that we can see in patients with Marfan's. Next, moving on to several other features that we could see. They have increased risk of spontaneous pneumothorax. So I mean spontaneous usually with patients that are usually very long. So most of the Marfan syndrome patients are usually very tall. So these are having spontaneous pneumothorax is usually, they have a 15% risk of having spontaneous pneumothorax, not according to trauma or anything, but usually just spontaneous pneumothorax. And also we have something called the ballooning of the dural area, which is called dural ectasia, which can lead to lower back pain. It can also lead to some neurological manifestations, pain in the legs, if of course this ballooning is pressing on a nerve. So the patient can have lower back pain and leg pains as well. So stretch marks, the patient will also have stretch marks, will also have striae, also inguinal hernias as well. So the next, what we're gonna moving forward to now is the mnemonic for Marfans. So of course the mnemonic is just gonna be Marfans for an easy way for you to remember and for students to remember. So Marfans, the first one is M, which is gonna be mitral valve prolapse for M. The second one, A, is gonna be aortic aneurysm. The third one, retinal detachment. And F is flexibility, also known as the joint laxity. So usually these patients are very flexible at their joints. And also you can use the F. Another mnemonic for F could be fibrillin 1 mutation, if you want to remember the genetic pathophysiology of this syndrome. And next, the A is arachnodactylia, the really long fingers, and also negative nitroprusside test. So this is a differential diagnosis that we use for homocystinuria. So usually with homocystinuria, we're going to have positive, but in this case, we're going to have negative nitroprusside test, and also subluxation of the lens, which is the displacement of the lens, upward displacement of the lens, known as ectopia lentis. And also the S can also stand for scoliosis. So as you can use that. So the next, we're going to be looking at the wrist signs. So the wrist signs in the patient is usually used in clinical practice to usually find what if a patient has Marfan syndrome. So what usually the patient can be able to wrap their thumb and also their fourth finger, the third and fourth finger wraps around. And as you can see, the pinky finger literally wraps all around. It can also touch the thumb of this patient. So that's also part of the things we're going to see, because the patient has joint laxity and also arachnodactylia, also long fingers. And I mean, if a normal person does it, your thumb and your pinky can't really wrap around your wrist. Okay. So next we're going to look at the next sign, which is the thumb sign. So the thumb sign is when you close your fingers with your thumb flap against your hand. The thumb should not pass the ulnar side of your forearm. But as you can see in this patient, when the thumb is closed against the other four fingers, you can see the thumb coming out through the ulnar side, the side towards the pinky of the finger. Okay, this is also another very prominent clinical manifestation of Marfan's, and this is called the Marfanoid habitus. So when we look at this patient, we can see a various number of things. First of all, you can see the very long arm, the very long legs of this patient. Of course, the arm span is going to be bigger than the length of the body. So if the patient should open their arm and stretch it on both sides, you could see that they have really long arm span. And also, we're also going to see the chest. You can see the very prominent chest manifestation here, which we have the pectus ectovatum and also the pigeon's chest, basically. So there's a special type of chest for this patient, and you can see usually but not always, the patients are usually very thin and very lanky. So as you can see, they have a really thin thin body. Next, we're going to go to the fingers. I've spoken about this before. Arachnodactylia, as you can see, really long fingers and toes as well, but usually not on the toes. But yeah, we could see it on the toes, but not always. But very prominently, we can see the long fingers on the arms, on the fingers of the arms. Okay, so next we're gonna go to the next one, which is the pes planus. Pes planus, that is the flat foot. Patient has flat foot. They don't have the normal curve that we have down here. So the normal curve of the patient on the legs. Next, we're gonna look at the joint laxity. Usually, the patient has very mobile joints. Patient has very mobile joints, and so they can easily bend their joints, bend their fingers, very flexibly. Okay, next we're going to look at the next one, which I mentioned before, which is the ectopia lentis. So the upward deviation of the lens, as we can see here. So it looks like a sun is trying to rise or something like that. Yeah, so that's that for that. And next we're going to look at the protrusio acetabuli. Usually in the normal joints we have the space between the head of the femur and here the acetabuli. We could see that there's a normal joint space, but over here, due to the the protrusion of the hip, you can't see. It's usually totally obliterated here, and we can't see it on the hip of the patient. So yeah. Next, we're going to see the dural ectasia. So usually this is going to be seen on MRI, usually subclinical, but it can cause back pain, as I've said, lower leg pain, incontinence, if this impinges on a nerve. So we can also see this in neurofibromatosis, also in Ehlers-Danlos syndrome as well. Next, we're going to go to the next sign, which I mentioned, the ascending aorta aneurysm. So over here, we could see that the bulging of the aorta. So usually it's best to diagnose this via an X-ray. Next, we're going to see the aortic root aneurysm. Aortic root aneurysm, here we could see the very prominent bulge in the root of the aorta, and we can know also that the first few branches of blood vessels here is going to be the coronary artery. So this can be a very big problem for patients with Marfan's syndrome. So having that bulge at their the aortic roots. Okay, so next we're going to go to the aortic dissection. Here we can see that we look at here for the intimal flap. Here we could see this right in the middle. Here we have the intimal flap. So and here also on the left you can see the true intima. So there's going to be this dissection that divides the lumen of the aorta into two. Next, okay, for development, usually physical development, some hypotonia may be present early in life. Children will track tall for expected height. So many children will discover that they are double jointed at this point. Also cognitive development, they might also have severe myopia and may cause difficulty in school if not diagnosed early. Also social development is gonna be normal in this case. Next, we're going to look at diagnosis. Marfan syndrome is a subclinical diagnosis. So genetic testing plays a secondary role in this. So we're going to try to do some initial workup for the patient expected to have Marfan's, a comprehensive history and physical examination, of course. cardiovascular workup, electrocardiogram, echocardiography as well, radiograph of the hand, the spine, the pelvis, the chest, the foot, the skull. So having a proper radiography of all these parts of the body is very important in making your diagnosis. And next, we're also gonna do MRI to see the dural ectasia, usually because, as I said before, it's usually asymptomatic, so you have to do an MRI to be able to see that. You also have to make a referral to the ophthalmology for slit lamp examination. So in addition to this, we're going to do the the systemic scoring. And this systemic scoring, as you can see the whole list of all the symptoms that the patients can have in this case. And the magic number we're trying to look for is a score of 7 or more. So if the patient has a wrist sign and a thumb sign, we give that a score of 3. If the patient has the wrist sign or the thumb sign, so either one of these, we give this a 1. The pectus carinatum, a number of 2. Pectus excavatum 1. Chest asymmetry 1. Hind foot deformity 2. Pes planus 1. The history of pneumothorax, spontaneous pneumothorax, not just any pneumothorax, that's going to be 2. Dural ectasia 2. Protrusio acetabuli 2. The arm to height span greater than 1.5 times, or a decreased upper segment to lower segment ratio, so we give this a number of 1. Kyphoscoliosis or thoracolumbar scoliosis 1. Facial features, as we've mentioned, the long narrow skull, enophthalmos, microretro, nathia, etc., and so on, we give that 1. Then the striae 1, myopia 1, and mitral valve prolapse, a score of 1 as well. So next we're going to look at the making a formal clinical diagnosis of Marfan syndrome. So number 1, we have to know that if the family history of Marfan, if the patient has a family history of Marfan syndrome, of course that will make it a lot easier to diagnose the patient. So if the patient has a presence of family history, so systemic score of more than 7, we know that that's going to be Marfan syndrome. In addition to the presence of family history, the patient has an ectopis lentis, that's equal to Marfan syndrome as well. And in the presence of family history and aortic root dilation, we're going to see, the patient has Marfan syndrome. But if the patient is younger than 20 years old, we're going to try to look for a systemic score of just 3, not 7 in this case. And if 20 or older, we just look for a systemic score of 2. Now, if the patient doesn't have any family history of Marfan syndrome, we have to try and make some, finding some extra information, or try to look for some extra factors to be able to prove that the patient has Marfan syndrome. So in the absence of family history, we look at the aortic dilation. Patient having a Z score, a systemic score of greater or more than 2, plus ectopia lentis. So we're gonna rule that as Marfan's. Or also, if the patient has an aortic root dilation more than systemic score of 2, plus a systemic score of more than 7, then the patient has Marfan. Then aortic root dilation has a systemic score of 2, plus any fibrillin 1 mutation during genetic testing, we're going to rule that as Marfan's. Or if the patient has ectopic lentis plus fibrillin 1 mutation, also known to cause aortic diseases, we're going to rule that as Marfan. But finally, if the diagnosis can be clinically provided, discriminating features of any alternative disease is not more likely. So if you're able to find an alternative diagnosis, after proving this. So it's not so likely that you will get another diagnosis apart from this. Next, differential diagnosis. Marfan's syndrome has a lot of similarities to some other pathologies, and to some other syndromes as well. So first, we're going to look at the first one, which is the mass phenotype. So mass stands for mitral valve prolapse, M. A stands for aortic root diameter increased. Striae and skeletal features consistent with Marfan's. So these features can also be seen in Marfan's, but we have to also consider if the patient doesn't have a family history of Marfan's, and if the patient has increased aortic diameter. Usually patients with mass phenomenon don't have a progressive increased aortic diameter. Well, the aortic diameter is going to be way less than if the patient has Marfan's. Usually the diameter for patients with Marfan's is a lot larger, but also their systemic score is not going to be 2 in this case. The aortic diameter is not going to be 2. These patients should be followed up carefully with ECG to ensure proper diagnosis. The next differential we're going to make is Ehlers-Danlos syndrome. Again, Ehlers-Danlos has so many similarities with Marfan's, but also has some specific differentials. So they share joint hypermobility. So that's going to be the variant Ehlers-Danlos syndrome, the variant of the hypermobile type. Also, they also have the aortic complication as well, same as Marfan's. They also have ectopic lenses. They also have some ocular manifestations. But in this case, there will be additional connective tissue signs, such as eye bruising, stretchy skin, blue sclera, droopy eyes, and poor wound healing. And they might also have some gastrointestinal symptoms as well. And so to make diagnosis of Ehlers-Danlos, a lot of cases we don't make genetic testing for Ehlers-Danlos syndrome. We have something called the Brighton criteria for Ehlers-Danlos, but to find the genetic testing, the CLO3A1, which is something that is definitely not common with the Marfan's. So when we see that, we can see, okay, that's going to be a differential diagnosis for this syndrome. Next one is going to be the Loeys-Dietz syndrome, which also shares another common similarity with Marfan's. It shares some cardiovascular and skeletal features with Marfan's, except for long bone overgrowth. It does not cause ectopia lentis. Patients additionally have features that may include hypertelorism, broad fibular uvula, easy bruising, arterial tortuosity, congestive heart diseases, Chiari 1 malformation, club foods, learning disabilities as well. And we can also do genetic testing in this case. And what we're going to be looking for is going to be the TGF BR1 and the TGF BR2 genes in this patient. What next? The aortic root aneurysm happened at smaller dimensions and at a younger age. So the aortic root aneurysms in this syndrome is going to be a lot smaller than that of Marfan's, and usually occurs at younger ages. Next one is going to be the Sprintzen-Goldberg syndrome, which is very, very similar to the Loeys-Dietz, but no cardiovascular manifestations. But also in this one, we have the fibrillin 1 mutation as well. And finally, as I've mentioned, the homocystinuria, which can also be a very big differential for Marfan. So they also share the same tall stature, long bone overgrowth, ectopia lentis. But in this case, as I've mentioned, it's going to be downward deviation, not upward, like the case of Marfan's. And is not associated with aortic dilatation. Patients also often have intellectual disabilities, increased risk of thromboembolism, coronary artery diseases, and so on. And usually the diagnosis, you also try to look for plasma homocysteine. And then management. Usually the management for Marfan usually includes preventative and surveillance annual examination by cardiology, including the echocardiogram. We're going to do this in able to make sure that the aortic root is normal and that the progression is going to be a stable progression. And we're also going to give beta blockers, which are traditionally considered the standard in for us to be able to reduce the risk of aortic dissection. Also, annual evaluation by ophthalmology, monitor for scoliosis, referral to genetic counselor. Also, we're going to have some life-threatening complications as well, aortic aneurysm, and in this case we know that we're going to have to do definitely some surgical repair. Usually the indications for this is if the aortic aneurysm is more than 5 centimeter, or if it grows at 1 centimeter per year, or in a case of severe aortic regurgitation. So these are the indications that we're going to do surgical intervention, and also maybe performed sooner if there's a family history of aortic dissection or rupture. Next, we're going to another life-threatening complication is going to be the acute aortic dissection. So signs are going to be tearing pain in the region of dissection, which invariably involves the aortic root, neurovascular insufficiency, rapid onset congestive heart failure, myocardial infarction, which with sudden death due to involvement of the coronary arteries. And also, we know that the only treatment we can give in this case is to do an emergent surgical repair. And next, we're gonna do the long-term considerations for patients with Marfan's. So, of course, they're gonna have regular follow-up and monitoring. These are essential to minimize the risk of potential lethal cardiovascular complications. And also, we're going to do some genetic counseling for the patients, because very soon they're going to start asking about, their chances of being parents or having children, or, if they're trying to consider parenthood. So you have to explain to them that if their Marfan was familial, meaning that if both parents have it, so there's going to be a 50% chance of transmitting this to their children, because most cases of Marfan is familial, so 70% of cases. And if it's sporadic, it has a less likelihood, a 30% chance of transmission to the offspring. So that's it for Marfan syndrome. I hope I try to explain what we can see with patients with Marfan syndrome, and how to be able to see clinically and make a clinical diagnosis for patients with Marfan syndrome. Thank you for your attention.